Thank you, Beth. And I always get the first lecture of the afternoon, which means I have to make sure nobody sleeps. So I have to keep it interesting, funny. But this lecture will be a little intense because it is all about transcatheter valve intervention. So I'm mainly going to focus on aortic valve disease, maybe a little bit on mitral, because then Asia is going to cover more of the mitral clip and other mitral valve disease thing. So just to tell you, if you go future of transcatheter heart valves, how did we come to percutaneous heart valves? So if you see here, the first valve that really became percutaneous was the Melody valve, which was very easy to replace in the pulmonic artery. Then the aortic valve, similarly, Sapien was used. The same aortic valve was used in the mitral space, and more of the mitral valve we will discuss also with the clip, and the similar valves are also being used in the tricuspid area. So essentially, all four valves have some kind of therapy being done percutaneously. So in 1989, this is how Anderson stent valve, what he did was just took this coil and used it in a pig to see can we do a percutaneous valve to be done. This is how it was the first experiment being done on the pigs. And then Alan Crebier, he is the one who just did a sketch of how the valve should look. So if you see here, this is how the current valve actually look. So they just took a metal piece and then attached the pericardium to make it look like a normal valve. This was 1989. Then this is what they thought we will do, that we will have a balloon, and on the balloon we'll place a stent, we'll go to the aortic valve, and we'll expand and place it. This is the sketch that was initially drawn by him, how can aortic valve be replaced. And he's the father of transcatheter valve therapy. So this is all we always say. First you think, you dream, and then it becomes the reality. So this is how the percutaneous valve came into existence. But in the early part, if you see how it happened, was 24 French. So the first person that he replaced, you see that? His conclusion, non-surgical implantation of the prosthetic heart valve can be successfully achieved with immediate and midterm hemodynamic and clinical improvement. 2002, and came out in a circulation as a publication. So what I'm going to go over is the top advances, what has happened in last year, 2018, on the valve therapy. So the first one we'll talk about is tricuspid valve intervention, and mostly we'll focus on TriLuminate trial because we are part of this study. So if you see the trend in the United States mortality, and several studies, several registry has always shown that presence of tricuspid valve, just isolated tricuspid valve, or in the presence of any other, that concomitant means your survival is poor. And that is why this paper, what it showed was landscape and changes and future direction for tricuspid valve intervention. So what did it say is there are various therapies that are available. One, at the level of the valve itself, a device, to coapt the tricuspid leaflet, annuloplasty, this is ring annuloplasty, and other one was using a stent in IVC. Rather than going to the tricuspid valve, inferior vein cava goes into the right atrium, then right ventricle. So can we do something at the level of the IVC? So several things have been tried, essentially trying to see which would be the best therapy for tricuspid valve intervention. So predictors and procedural as well as clinical outcomes were shown in this particular paper. So what is TriLuminate trial is the TriClip system. This is a system which is exactly what we are using right now for mitral clip, is the same system. Similar way is using a clip with the grippers, and the TriLuminate study, we are part. There are only 4 centers in the United States, and we are part of it. Myself, Dr. Gilbert Tang, are the PI, and right now doing procedures by using clip for patient with tricuspid disease. So ongoing trial and future studies are going on. This is to say that the tricuspid valve itself is so complex. Like I showed you, there are so many devices. It just gives you an idea to tell that we are still not sure what is the therapy that would probably ideally suit for this valve. The next one is sentinel protection device to be used during TAVR. So essentially what happens during TAVR, if you look at it, this is how the aorta looks in this elderly patient. A lot of calcium and atherosclerotic material. This is the CT scan picture of these people. So as I showed you how the TAVR valve goes, it goes through the femoral artery all the way, descending arch, and then we go to the valve level. So when we are traversing all these places, as well as other thing is, if you look at the native stenotic aortic valve, heavily stenosed, calcium, and a lot of debris, could be even some thrombus sitting in this particular area. So when we are doing the procedure, a lot of things could be embolized, and where would normally go, the first thing it goes is to the great vessels. So the risk of stroke is there, and I'll show you what the risk of stroke is. So what they did was to put some, this we called as umbrellas in the carotid, and this is what they captured. All this is captured debris in particular thing. So the risk of stroke average in the initial trial was between 4 to I would say greater than 9% if a neurologist has seen, because when a neurologist examines, they probably even look at minor details which average people when we examine will not get it. So we would say the stroke rate was close to about 5%. That's the number you need to remember with the initial trials. But subsequently, the number has gone down. So that is when they decided, is there something we can do to prevent the stroke? And this was a sentinel protection device. You actually go from the right radial artery, and you will go in and you will get into the right carotid first. Then you will rotate the device in such a way that then you'll get into the left carotid artery. Though it looks very complex, it is a nice device, and usually does not take more than 2 minutes to get in and place this device. So what did the trial show? Not clinically significant, but definite reduction in stroke when this particular device was used. So the current practice is such that every patient will get a sentinel device unless there is any contraindication, if there is any problem with the radial artery or aortic arch pathology. Now, once TAVR is placed, always the question comes, like you have heard so many talks on after stent, what do you do with antiplatelet therapy? What we are discussing is it antiplatelet therapy that they should be taking, or they should be taking antithrombotic therapy post TAVR in this patient? So is it a single therapy would you just give aspirin? Would you just give clopidogrel? Do you need dual antiplatelet therapy? Or do you need anticoagulation, which is with Coumadin or any kind of the newer anticoagulant agents? So we're still not sure, because there are several trials there ongoing, which you will see. And why this came into existence is based on this particular, I would say, the case report that came out that after placing the TAVR valve, if you see here, this is normal valve which should look like. This is the MR, the normal leaflet. These are closed, these are open. That's how they look. But if you see here, what you're seeing is a thickened leaflet. So this is not normal. Why did it thicken? Is there was a degeneration, means something happened to that valve, or was it thrombus? What they found was it is mostly thickened leaflet due to thrombus. So how can you clinically make that is why everybody gets echo intra-procedure. There is an echo doctor during the procedure who will check the echo, though they don't do a gradient at that time. Next day, they'll do a echo gradient. So you'll have a baseline gradient. Usually, post-procedure gradient should not be more than 7 or not more than 10 millimeters of gradient. So if this gradient has increased, they come and see us at 30 days. So at 30 days, if the gradient has increased by 10 millimeters of mercury or a new gradient of 20, then you know that that is a definition of valve thrombosis. And what is the treatment for this? Is that based on a couple of this registry data that you see, that you can give anticoagulation, and definitely that this particular, that thrombosis has changed. So this registry, what did it show? The significance that OAC, oral anticoagulation therapy at discharge, had a significant lower incidence of valve thrombosis. But several trials are ongoing. We are part of some of these trials to understand which would be the best treatment strategy for this patient. At this time, we are only using a dual antiplatelet therapy, which would be either aspirin or Plavix, and one of them we stop at 6 months. Now, what was a Galileo trial? That they used NOVAC, and what actually happened at 6 months, there was a high risk of bleeding, so DASNB actually stopped the trial, and the results are awaited. Now, we know the TAVR was for aortic stenosis. Can we place the prosthetic valve for pure aortic stenosis patient? Now, what is the big difference in the pathology of aortic stenosis versus aortic regurgitation is what we see here. So this is aortic valvular stenosis, which I already showed you. Why the valve is narrowed, you see that? It's presence of atherosclerosis, calcium, everything makes this valve narrowed. You need calcium so that the valve we place is anchored and stays there. If you do not have calcium, this is aortic regurgitation. There's nothing wrong in this valve itself. It is just maybe there's some dilation. The AI usually does not have any calcium. And also what we call is they come with the aortopathy, which means there is dilated sinus, dilated aortic root. So there's not a true valve yet. The current valves that we see right now that we are using for aortic stenosis are not meant for aortic regurgitation. So therefore, at this time, we are not placing it for pure aortic regurgitation. But definitely, these are the, for aortic regurgitation, what we have seen here. These are the valves which are being made for pure aortic regurgitation, and this is different kind of valve. You see that? You want something to anchor so that it will stay there, and the term we normally use is that it does not fly out with you. That you place the valve, you're coming out of the room, the valve is coming out with you. That cannot happen. So it has to be anchored. That is why, if you see here, these valves have special anchors that they will stay in the body. So the trials are ongoing for this particular therapy. Now, TAVR, we know, I'll go over some of the indication at this time, who should be getting TAVR. What are the emerging indication? And that is one great thing about interventional cardiologists. We never, once we hit the target, we are not happy with that, we have another new target. So we are like, okay, we hit aortic stenosis, we are not done. Let's see what else we can go for. So what are the newer thing? Low flow, low gradient, then valve in valve. And what we are talking about is early. What is early means? Right now, the indications are you have aortic stenosis and you need to have symptoms. There are patients who have severe aortic stenosis, which means your echo, your gradient in the echo is more than 40 millimeter, which is a mean. If it is more than that, but there are no symptoms, that's called early. Can we do something to them? Or what is unload? So let's go over one by one. So same. Moderate to severe aortic stenosis. If patient has moderate to or severe aortic stenosis and has symptoms, especially of heart failure, is there something we can do to this patient by placing valves so that the heart failure get better? Valve-in-valve prosthesis. That means they already have one bioprosthetic valve, not metallic, bioprosthetic valve replaced. Can we place the TAVR valve in patients who have had prior bioprosthetic valve? Bicuspid is another pathology. This means the person, normally what happens is the picture that I've shown, there are 3 leaflets. Aortic valve have 3 leaflets, but you could be born with only 2 leaflets. And if that's the case, they usually become symptomatic in their 40s or sometimes maybe early 60s. So if it is bicuspid aortic valve, usually what happens is the pathology is such that normal valve does not behave well in these patients. So moderate AS with CHF and early TAVR is what I just discussed. It's the same that you have AS, but asymptomatic. Would this patient benefit? Early means same. You don't wait for symptoms. Can you do TAVR? Would their life expectancy change? And alternate axis. Right now, what the TAVR is that you want to do TAVR percutaneously means you want to do femoral axis because a lot of the other axis do have some complications. So this is the for low flow, low gradient. This is what the algorithm is. Same, your mean gradient is less than 40, but your EF is less than 50 also. You'll do dobutamine stress echo to see if your gradient goes up. And if this patient gradient has gone up, that's when you consider TAVR versus SAVR. And this is ongoing at this time. And what can This is the initial registry data saying that can TAVR be placed for previously implanted surgical valve. This is a case just to show you. If you see bioprosthetic aortic valve here, previous valve. So this is a sapien valve, which is right in there. We are positioning it. So what happens is we go pacing very high speed so that you do not want to have a cardiac output. When there is a cardiac output, the valve will move out. So you want no cardiac output, cardiac standstill almost for, I would say, 15 to 20 seconds so that the valve is positioned and placed at the right place. So this is exactly what we do. So you have two valves. You see that? You're able to appreciate the previous valve, and now you have the second valve in valve. So TAVR valve in valve versus TAVR for native aortic stenosis, if you see the differences, definitely there's a big benefit of doing TAVR rather than going for a second open heart surgery with regards to hospital stay as well as the incidence of I would say, stroke. Now, severe bicuspid aortic stenosis, I think this is where the problem is, and I would want to go over this, that what are the regular aortic stenosis? You have annulus and asymmetric leaflet calcification, or you have raphe. So because of this issue, concomitant aortopathy, and we don't know what is the long-term durability of this valve in patients with the bicuspid aortic valve. Since we don't have any data, the trials are ongoing now to see if the same valves that have been, okay for the regular AS cases can be used for bicuspid aortic valve stenosis. Now, asymptomatic patient, just to give you an incidence prevalence, 40 to 50% of all severe AS from the database, what will happen is isolated asymptomatic severe AS represent about 30% in the population, about 500,000 patients over 65 years old in the United States. So this is just to tell you there are a lot of patients with AS out there, but unless they have symptoms, they don't present to you. So the natural history of the disease is the same, that you do not wait for the symptoms. Means the symptoms means as soon as they come with some minimal symptoms, you need to take care of them rather than wait till they have severe symptoms. The severe symptoms could be either syncope, or the worst is if they actually presented with the heart failure. So early TAVR, this is where the flow is. If they're asymptomatic, which means the negative stress, randomized 1-to-1 for transfemoral TAVR versus clinical surveillance, and then to see what is going to happen to this patient. Now, TAVR unload, very important. Your EF is less than 50. They have moderate AS, and the question is the same. Do you go for TAVR or do you continue heart failure therapy? This is a trial which is also ongoing to see what would be the outcome on this patient. Then vascular access. I know I've mentioned everything going through the femoral. There are other things that have being discussed, and more important is that there is a carotid. You can do TAVR via the carotid. There are a couple of reports from there. So essentially, we're trying to see how we can get there from whatever possible route here. So this is also ongoing. Coming quickly to the trials of the mitral valve is, if you see here, the landscape of the mitral valve replacement and the devices. The number of devices that are out there, it just goes to say the mitral valve is a complex valve. There's no single valve yet to say, yeah, this is the valve that we are going to use. It is just a very complex disease. So these are the valves that two valves are being out, which are in the trial, Abbott 10-dime valve and Medtronic 12. We are actually part of this particular trial, which is called the Apollo trial, and I'm going to show you what it is. It is done via the apical axis, and look at the size of the catheter, 35 French. So you have to go from the apex, go to the mitral valve, and when you're at that particular right position, then you place the valve. And what's the biggest issue with this? Two things. One, embolization. You think you placed it in the mitral position, next minute it's in the left atrium. 2, thrombosis. So yeah, we are part of this trial. It's ongoing, very poor enrollment, but working on it. So what we can do, or what people have tried, is that if there is a previous mitral valve, prosthetic valve, can we do something? So how mitral valve being treated? Either they're getting repair, they're getting a ring, or they're getting replaced by a previous prosthetic valve. So for these particular patients, can we place a valve? So this is the clinical outcome for most of them, which is valve-in-valve, that you're placing a valve for a previous mitral valve, you're placing a valve for the previous mitral ring, or you're placing a valve for MAC. What is MAC? Mitral annular calcification. That means it has developed MR or mitral regurgitation, but there's a lot of calcium around the mitral valve annulus. So what it suggests is valve-in-valve is something that is doable. The rest would be having a very high complications, and this is what it is. So valve-in-MAC, absolutely no, because very high overall mortality complication is very high for valve-in-MAC. But valve-in-valve is something that is doable. So we do have several TAVR valves. The question is which valve is best for the therapy here. So there are a couple of trials out there which have discussed balloon expandable versus self-expandable. These are the 2 FDA-approved valves that are now available out there. So balloon expandable versus self-expandable, most of them are identical, except you see the pacemaker rate is slightly high for self-expandable, which we know, versus there was difference in stroke, which again, there's not significant. Only significance was maybe slightly higher rate of pacemaker rate. Now, SOLT-ALV is the same. Symptomatic aortic stenosis, whether you go for core valve versus SAPIEN valve, you see, and then they're randomized again for general anesthesia versus local anesthesia. No difference whatsoever except for pacemaker implantation in this patient. So this is where I think we can say, where would you favor one valve over another valve? So SAPIEN, again, antegrade approach, very large annulus, horizontal aorta, concerns of PPM, and extensive coronary artery disease, low coronary height. If these are the concerns, you would go for SAPIEN, and I will go over this, why, if you have extensive coronary artery disease, that you would want SAPIEN valve over Evolute, and why, if a coronary height, I'll go over that again, because when you are placing this valve, your native aortic valve will be behind. It will go and obstruct the coronary arteries. So if your coronary height is low, you have to be careful, and we need to protect the coronaries easier with SAPIEN compared to Evolute. The best Evolute would be for valve-in-valve. Why? The biggest difference, this is intraannular valve, this is supraannular valve. So since it's supraannular valve, your hemodynamics are excellent with this particular valve. So it's not one particular yes, no. So you have to take several things into account when you decide which valve is best for which patient. And that happens during our heart team discussion, which happens every Monday morning. Now, coronary angiography post-TAVR, we were the first one to publish about this post-angiography that came out last year in American College of Cardiology, the journal, which discussed everything about the valve. So like I mentioned, when you're positioning the valve, there are a couple of things. One, where you positioned it. These are the various valves. You have the skirt, the leaflet, the length of the valve. So a lot of things were taken into equation. But I think this is the picture. This was a central figure of that publication telling us what are the factors that you need to consider when you are placing the valve and when they come back. This is not valve because they survived. Now they come back because they have angina or they're presenting with non-QMI. You need to know how to do angiography through this particular valve. So what are the things that you need to consider? The dimension is not that much. You see that what happens? Leaflet length and bulkiness. The longer your native leaflet, you see what's going to happen? If you see here, the leaflet will go and obstruct the coronary artery. Also, the way the valve is oriented, right? So this is called as a commissural tab. So you see the commissural tab goes all the way high, and if this is very close to the left main, so when the patient comes back, how are you going to engage? You got to make sure you're engaging from this particular diamond or this particular diamond, which would be very difficult. And this particular thing resulted in the publication here, and also resulted in the app, which I will show you at the end. And this was the algorithm which we proposed, that if you come with this particular valve, which catheter you need to engage, whether you're going to the left side, the right side, the size of the catheters, everything. And this review has been very well cited since then. Then TAVR for low surgical risk. Why we are talking about this? Like I mentioned, when TAVR came out, it was meant for extreme risk patient. Okay, extreme. Now, what are we talking risk? Which is called as STS risk, where they take patient age and several other comorbidities. So it starts anything above less than 3 is called as low risk, 3 to 8 is intermediate risk, above 8 is high risk. So these were essentially for extreme risk, where they compared medical therapy versus TAVR, and definitely TAVR got better. Then from there they went to intermediate risk, and subsequently they went to, this is the intermediate risk where they compared TAVR versus surgery. Definitely TAVR was better. So these are the current indications, what we are talking. So this is the STS risk score. So extreme risk, high risk, we definitely know TAVR is indicated. Intermediate risk is, like I said, 3 to 8. Based on this particular trial, TAVR indicated. So what happened was, like we said, we interventionalists kept moving, started going, encroaching every area. So if we started here and came to the low risk. So the low risk trials were presented, during the ACC, but we still don't have a clinical the indication yet that we will have it soon. So these were the trials, TAVR versus SAVR for the low risk, which again said that TAVR is better. Taking everything into account, only thing, like I mentioned, the difference was pacemaker implantation in this particular case. And this was ACC presentation with simultaneous publication in New England Journal. Among patients with severe aortic stenosis who were at low surgical risk, the rate of composite death, stroke, rehospitalization 1 year was significantly lower with TAVR than with surgery. Okay, very important, lower than with surgery. This was the Partner 3 study trial. This is the same for the Evolute. So New York Times, what did it say? Tens of thousands of heart patients may not need open heart surgery. So because we attacked from high risk to intermediate risk to low risk, and we are just waiting for a final FDA approval and CMS mark, and then we will go to the low risk patient also, essentially saying most people do very well with TAVR in this day and age. So if you go to the current guidelines as of 2017, so what is the thing we say is not who is suitable for TAVR. Now the question is who is suitable for SAVR. SAVR is surgical aortic valve. Essentially we are saying that prohibitive risk, TAVR class 1. Surgical high risk, again, will be TAVR or surgical AVR class 1. Intermediate risk is already surgical, TAVR became class 2. It is actually will become TAVR class 1. And low risk was AVR. Now based on this, our trials will change to TAVR also, the TAVR for all this group of patients. So the last thing that I want to go over is quickly for mitral clip, which is for essentially, we know when the clip was approved, it was approved for degenerative mitral valve disease. And mitral valve disease comes into two components, degeneration as well as a functional. Degeneration means there is pathology of the mitral valve itself. Functional means for whatever reason, usually you take into consideration patients who have heart failure. So they have dilated LV, dilated annulus, and that's why they develop mitral regurgitation. So based on the trial, which is called as a COAPT trial, which was also presented, which showed we do not have the approval. What was the COAPT trial? Randomization, mitral clip plus guided medical therapy. And very important, what is guided medical therapy? Heart failure doctors were involved. Patients were on ACE inhibitor, diuretic, and beta blocker, compared to just guided medical therapy, that they did not get the clip, but got guided medical therapy. So the big difference here is that they were on good medical therapy, they were still symptomatic, still had MR. So those are the patients who got the clip. And what did it show? They looked primary endpoint of rehospitalization at 24 months and also mortality. It showed a big difference in here. So the composite endpoint you see here, this is patients with the guided medical, this is with the clip, and this is guided medical therapy, close to 50% reduction, showing that clip therapy on patients who have good medical therapy is essential on this case, for these patients. Now, majority of the patients, okay, if you see here, 94% of the patient were who got single clip, and this is what the device things were. Now, all-cause mortality. This is very important to say that any device that is being used, and you're saying that there's a difference in mortality in this patient, that is one that actually made everybody surprised that the clip would help in this group of patients, and that was for hospitalization, repeat hospitalization. This is the same mitral clip plus guided medical therapy was better than anything else. So if you see here, what are we trying to show? That patients who were heart failure, we are talking that their need for heart transplant, need for LVAD, or either of the two was decreased once they became therapy as well as when they went on clip. So this is something that everybody, I think, should be a take-home message for you guys, that this is the therapy works in patients with heart failure. If they are on good medical therapy and they're still symptomatic, they should be referred for mitral clip therapy. So to conclude, patients with heart failure, moderate to severe or severe to secondary mitral regurgitation who remain symptomatic despite maximally tolerated guided medical therapy, the mitral clip was better, and this will help. Why? By improving prognosis of the patient with heart failure as well as reducing MR LV function. So we expect clip soon to become ACC class 1 indication for functional mitral regurgitation based after they have guided medical therapy. So essentially we are trying to say that we will have to open a new lab since we will have low risk available for TAVR and a COAPT. Yeah. So this is what we are here. What we discussed is what is good, TMVR, TTVR, BAV, and for the TAVR, Sentinel is plus minus, okay? And this is what is very good, is valve-involved TAVR, clip for functional regurgitation, and TAVR for low risk is lot thumbs up, patient survival. So I just want to, so this is projection, okay? That 2018, 5,000 TAVRs per month in United States. But projected for 2018 was this much. For 2019, we expect it to really go to probably 80,000 or so. But what you need to know also is, like I think Beth mentioned in her talk, it is not just that you need to also think about in-hospital outcome and outcomes outside the hospital, mortality, vascular complication, bleeding complication. Everything has been followed, and right now every complications are less than 1% even in the TAVR. This is Mount Sinai volume from 2014 to 2018, and we have done, I think, a few cases in our sister hospital. So this is where we are. So observed O to E mortality ratio, which is very important, is less than 1. And this is what we need to goal for, that your mortality is low, less than 1 for this patient, and length of stay is less than 3 days. So this is what our outcome is the same readmission. This is a TVT registry. The entire, what happens is ACC keeps a registry of every patient that gets TAVR. So if you compare to registry, we have slightly higher PPM, but other than that, we are very good. But this is important also, readmission rate, very low, because this goes with hospital reimbursement. Now, like I think we did our live cases yesterday, we do the live cases for structural heart disease. We do it every other month, which is a Tuesday at 9 a.m. So they have to say which Tuesday is the second Tuesday of the month. This is just the web hits. And this is the app which we made based on the review article that I did to say, you can see here, this is an animation to say how you can engage the coronary arteries once you place the TAVR valve. Because there have been cases, reports, where patients came back and they did not know how to engage and embolize the TAVR valve. So it's very important you know exactly how to engage after the TAVR valve. So this is the animation we created to show how you can engage this. And this is what is available on that app. This is the left coronary artery, right coronary artery. This is the sapien valve engagement. Okay, thank you. I think I move on to my next presentation, right? After the complex and very intense talk, I think I need to go to some relaxing talk now, right, guys? So what we are going on to is digital transformation of the cath lab, okay? What I'm trying to tell you guys is the time is here. For the next, I would say 10 minutes, you need to stay plugged on. What is it? So let me talk about what patient services are and how patients are currently referred to the cath lab. So here we are, our cath lab admitting people who are there. What happens? A phone call comes either from the doctor or from the patient itself saying that, can you get this patient on the cath schedule? So this is what happens. They're taking everything and multiple questions go on and telling them what to do and what it is and all these things. And they will explain to the patient how a procedure is being done. What is a cardiac cath? They will explain to the patient, and this is what you are on this side of the phone thinking that that is what the patient understood and coming here for cardiac cath. But what did the patient really understand? This is what is going to happen to me when I go to Mount Sinai. Next, make it easier. Everybody calls for directions, right? Okay, how do I get there? So you think this is the best way I made from the maze. I am telling this person how to get to Mount Sinai cath lab in the midst, but this is what the patient thinks. Still not able to find where the cath lab is. I'm sure everybody has had experience of finding a patient somewhere saying, can you direct me to the cath lab? So this is exactly the reality that they cannot find the cath lab. And all the directions and everything given by Mary. Where is Mary? Who calls the patients multiple times to say, this is what you need to do. How are they going to remember? We have no idea how they're going to remember all that. So this is what is going on right now. Post-procedure, the ADS NPs have to give them education. And then still we are not sure if they have understood how many medications they need to take and what time to take it. Okay, we hope they have understood what they've done. It is done most of the time. So now this goes on and on every day. And this is what happens to these people. Multiple phone calls, same questions over and over again. The question now comes is, and we have these books and other system. I think it's time we get rid of that. Why? Because we need to get to a digital transformation. What is the current thing that's going on? Everybody is on the smartphone. They're all looking at the smartphone. Nobody's looking at you and saying, hello, how are you? How was your day? Nobody does it. They're texting or putting you on all this, what are the names of those various social media stuff. Also, we see that healthcare is moving towards digital. And more important is personalized medicine. I hope everybody has heard the word personalized medicine. What is personalized medicine is that if a patient is referred to you, you take that patient in context of patient, saying that not every patient is the same, so you give a special benefit to this patient. Also, many patients, we think, have they met all what we call the best practices. And what is the best practices is same, what we just discussed. that several things: pre-procedure, post-procedure care follow-up, and follow-up with cardiac rehab and lifestyle modification. I think where we are lacking is this part, that are they all referred to rehab, and is lifestyle modification happening? We are not sure about that. Antiplatelet agent, and then capturing patient-reported outcomes. Again, which Beth showed, patient-reported outcomes is a key. Once they start reporting and they becomes public, you got to be out there so that you know your hospital is the best hospital, so that patient, right now everything is available on the social media, and you want to be the best, so patients come to you just by looking at it. And this is, you can. So what we decided was, we did a collaboration, which is Mount Sinai Cath Lab. This is RX Health, which is a company run by Dr. Ashish Atreja here in Mount Sinai. And most important is American College of Cardiology. American College of Cardiology wanted to put a system out there to say that we want to have a system that the entire USA will then adopt, so that it is uniform, how patients are being referred. Initially, we are going to do it in one stage, and then you will see how we want to extend. But there was no other lab other than Mount Sinai lab to be the first lab to make this happen. So we went digital. So everything that we were discussing will be on the phone, okay? And messages will go to the patients on their phone. So it will be the patient, and we'll also take the patient relative, whoever they say, the next of kin will get message saying, this is your day, this is the day you're coming for a procedure, and what all preparation has to go on. So then they have it on the phone, and they can go over it over and over again. And step-by-step instructions. The book that I made many years ago will now become digital, so no more paper copies. Go green for us. Avoid all the paper copies. So remember that maze, didn't know how to go. Right now, we'll be sending direction via the Google map. So there's no way, I hope they'll not get lost somewhere. They should know how to come to the cath lab and not get lost elsewhere via this direction. And
called coronary arteries have a really important job. They carry
why can't we hear the sound?
To the heart. But if you have heart disease and one of those arteries gets narrowed or blocked by plaque, that flow of blood slows or even stops, and that can cause a heart attack.
This particular video
is a procedure
will be sent to the patient
so
that they don't think some hammer and chisel is going into their artery.
Is not surgery. It doesn't use large cuts. It's done using a thin, soft tube called a catheter. A doctor inserts the catheter into a blood vessel in the arm or groin and carefully guides the catheter through blood vessels in your body and into the blood vessels of your heart. The doctor uses special dye and a camera to watch the movement of the catheter in the blood vessels on an X-ray screen. This allows the doctor to move the catheter right to where the artery is narrowed or blocked. Inside the catheter is a very thin wire that is used to move tiny tools into the artery. With these tools, the doctor can widen the artery and keep it open. One tool is a tiny balloon. The balloon is inflated for a short time, and the pressure from the inflated balloon presses the plaque against the wall of the artery, creating more room for blood to flow. Most of the time, the doctor uses the balloon to place a stent in the artery. A stent is a small tube that expands as the balloon is inflated, and it stays in the artery to keep it open. The balloon is then deflated, and the stent stays expanded and presses against the walls of the artery to help keep it open. The doctor then removes the balloon, guide wire, and catheter from the body. After an angioplasty, the narrowed or blocked artery is opened up so blood and oxygen can flow more normally into the heart muscle. These X-rays show a blocked coronary artery before and after an angioplasty.
This looks like our pre and post picture.
Before angioplasty, the blood flow to the heart is blocked by a narrowed artery. After the angioplasty, blood is flowing better through the newly opened artery.
So this is the one video that we are starting for this. They are already getting this video so that they know that what to expect while they're coming here. So we believe the key benefit of this particular platform, digital platform, is increased patient engagement. I think rather than the words, when they see it, they understand better, enhance patient experience and patient satisfaction. Since we believe this in a lot, patient satisfaction, word of mouth, so they are able to give have a better experience when they come here. Improved adherence, follow-up care, and patient outcome, because they'll understand about the disease process. Why I think there is a problem with adherence and follow-up care? Because a lot of people do not understand how serious their problem is. And because of that, since they understand, decrease phone calls to us as well as decrease readmission to the hospital, and then we are able to capture this. It's very important. All the data that we are doing is captured and it is nationally sent. And after a while, what will happen is all this thing that is in the EPIC, the EMR, whenever the final, the day of discharge, e-reports will go to the referring providers. That's the goal. So this was our team. If you see here, the entire Cath lab team worked with the group, and the first patient was prescribed on May 23rd, 2019. This is my team here of the lab. So far, as of 6/12, we had 433 patients they were prescribed. So thank all the nurse practitioners of the Cath lab, as well as I think 7 E's, but mostly nurse practitioners of the Cath lab. And I would say the nurses in the lab, especially I think led by Brian. He's big into this digital now. And this is a feedback we are getting from the patient. Look at that. Mostly 9 and 10, that they like it. They, it's digital, so they're well aware and what is going on with this particular case. And then guess what? This message was sent to ACC, Johns Rumsfeld, who is the ACC Innovation Office, and what he said was, it's great news, so excited to hear. It's a testament to Mount Sinai and the Cath lab showing how to implement digital health. We just need the rest of the country to follow this lead, okay? So this is the endorsement from ACC. So this is just the beginning for us. We have a long way to go. So we will work on structural, peripheral, heart failure, lifestyle modification, and more to come, how to change it. Just to give you a glimpse of other things that we are working, what is a smart Cath lab? If you see here, this is how the car was in the past, and this is the current new cars which we are having. Old Cath labs of the 1980s. This is, hopefully we get this more new Cath labs that look like this. So what is smart Cath lab? Essentially understanding algorithm, and what we call it is machine learning. And how do we do that? Is several of the apps that we have made is based on that. Why? So future Cath lab, this is what's going to happen. Using algorithms, and then the algorithm will tell the doctor how to take care of the blockage. Okay? So this is how Bifurcate app was built. I know you guys are just seeing it, but what was behind the app is this complex algorithm. This is only one sheet. We probably have 300 sheets of this. So this is how a complex algorithm works. So when you put that algorithm, an app comes out. So what our goal is to put this algorithm into a machine, which is the angiographic machine, and that will tell you how to take care of a particular artery. Similarly, yesterday, everybody was talking about why we are doing rota, why we are not doing orbital atherectomy, why we are doing cutting balloon, a lot of things. A lot of it comes with experience. The question is, the experience that we have, can we put it into an algorithm so that a machine learning, it is called, that subsequently that will help people guide therapy for patients so they have the best outcome. That is why this app came out. And I think AI for optimal PCI, I think Julia did talk to you guys about OCT. I was incorporating imaging for stenting pre and post procedure. Again, same thing we do is understanding who should be getting it, using imaging, and doing the best thing. And that's the app we have is for Octade. Thank you for your attention, guys.